Hello, my friends and colleagues in manual therapy and physical medicine. It is Mike in Seattle, still coming at you from my COVID-modified living room. And I've been having a lot of conversations recently with colleagues who are at some stage of contemplating a return to practice. And what I've noticed is that there's an anxiety that each of us carries with regard to how to do this strategically, how to have a framework that lets us incorporate the most important information and act upon it. Because we all want to do the right thing, and we all want to have a sustainable practice going forward. And so with that in mind, I thought I'd share with you some of the strategic considerations that I'm using. And this in no way is meant to be a recommendation for how you do or don't reopen your practice, but it might be useful, possibly entertaining, for me to go through my thought process here. So here's what I'm thinking about. Number one, I'm seeking durable solutions. I'm seeking changes in my practice that I can accomplish for an extended period of time, and also that are durable in many varying circumstances, because this pandemic is anything but static, right? So I'm seeking solutions that are tolerant of changes in prevalence of the disease, in whether I need to lock down again. All of that is on my mind. I'm also, this is a phrase you see in a lot of fields, but I've heard it most recently in athletic training: don't major in the minors. In this time, we are all inundated with a cacophony of potential solutions, commercial products, strategies, things that are kind of memes about how to do the right risk mitigation. And there's a wide range of evidence supporting this or that practice. And so there are some major things, that we should all be thinking about: mask wearing, hand washing, physical space between bodies when possible, right? There are plenty of things that would be fine to do, but you should not structure your plan around them. Things like a UV lamp, assuming you use it in a non-risky way, or things like certain cleaning products. These may be nice. It's fine to do them, but don't use them to structure your plan or to replace a better strategy, right? Of course, as we're doing all this, the temptation is to think that we need to figure it all out once. It seems so Herculean to do it the first time. Figure it all out once, and then you're good. But the reality is that there's so much we don't know. There's so much we don't know at this stage that if we're going to have a safe and effective return to practice, we need to be willing to evolve the model based on new information, right? So have that built in, that expectation, some review cycle, perhaps, right? I'm also, in all of the evidence that I use to evolve my model, I'm going to prioritize certain kinds of evidence over others. I'm particularly interested in, not exclusively, but particularly interested in outcomes evidence and synthesis from experts, right? So people who know how to weigh evidence and put it together, I'm going to pay attention to those voices as I prioritize how to evolve my model. All of this does not matter if you don't have buy-in from your coworkers, from your clients and patients. If you don't have other people willing to participate in these changes with you, they're just on paper, right? So whatever you do, make sure that people know why they're being asked to do this, and that you give them a solid opportunity to comply, right? Lastly, I'm going to have to move the camera down for this. Dun, dun, dun. Camera down. That's the camera down song. We're going to have, that's the notebook falling song. We're going to have, for many practitioners, it's going to be very useful to try to diagram the service, the healthcare service that you provide, so you can think about each step in the flow of the healthcare interaction. And so here's an example of a way you could diagram your service. This is kind of how I'm, scribbling about my service. Can you see that okay out there? I think so. Great. It'll be a little tilted. I apologize. Think about everything that is required for this healthcare service to transpire and all of the potential risks associated with that in terms of transmission of COVID-19, coronavirus. So, initiation, everything that happens before the patient or client enters the practice. How do they first schedule? How are they educated about what it is you're offering? What are the pre-screening questions and when are you asking them? Right? And what does the informed consent look like? What do they know or don't know that they're walking into? Secondly, here's where they enter your practice and they interact perhaps with a front office or just with you, and think about the physical contact, the airways, the distancing, and the airflow in these situations, right? Entry. Now you're in the treatment room here in the middle, right? And there is a clinical interaction. That's to say there are words and deeds that the practitioner is engaging in, and questions asked, things feeding back on themselves. Think about all the modes of interaction and what the risk is and mitigation strategies for each, right? Think about the effects of your treatment. That's to say, how does the person's body or mind change in response to what you are doing? Does that feedback on interaction? But does that have comorbid, perhaps, risks or convergent risks with this other risk of infection, right? Think about the actual clinical effects of your normal care and ask if that increases any possible risks. Also think about the outcomes, how people, are durably improved by your treatment, and again, does that change their behavior in some way that increases risk? I don't know, but it's a worthwhile question. Lastly, think about the end of the session. How do they leave? How are they equipped with information? How are they instructed to exit the building? And then, crucially, for those of us who want to see more than one person per day, the changeover. We are interested in that time and space between persons that we can change over the high contact surfaces in our treatment room, that we can make sure to change our PPE if that's what we're doing. So just think about everything there and come up with a solid workflow, because this is going to be the breaking point of your day if you haven't kind of practiced it. And that kind of brings me to the last point. Get this out on paper as best you can, not because it will go perfectly the first time you try it, but try some practice times. Make the time to come in first and perhaps go through a mock session with a trusted colleague. Work this out, practice this, and have some clemency for the fact that this doesn't go always perfectly according to plan. So I hope this was helpful and or entertaining, and I wish us all well. I think that there is a serious benefit to what we provide, and that should not be forgotten in all of our risk mitigation strategy. So seek out the experts, evolve the model, do all the things, and good luck to you.